Welcome to part 3 of the Prevention, Diagnosis, Treatment and Following Heart Failure webinar recording. This webinar was recorded on the 5th of November 2021.
Both speakers made very good points actually. Thank you very much for that. And I was just trying to see the question and answer section, and maybe you didn't see, but I think the last words of Sadi was very effective among some colleagues who were saying that, you know, this is touching to the GPs, you know. So we are saying that, you know, the cardiologists are having a little bit different than the internists or internal medicine concept, let's say. And this is really, we didn't think about it until now, maybe. But now when you say something like that, when we think about it, the comments are like that also. They are saying that they are surprised that you are telling it yourself as a very well-known cardiologist, but also it might be correct that somehow we are losing the psychosocial approach of the patient and the individual personal care also sometimes, if we are thinking about ourselves like a surgeon.
I think if we look at the evidence, that comment from Sadi is unfortunately borne out from research. So we were part of quite a big survey of about 12 countries where we looked at patients who had unstable heart failure, i.e. they had elevated natriuretic peptides, and these patients were referred to a cardiologist or a geriatrician in some countries for advice, and unfortunately there was virtually no change in treatment recommendations despite this. And the main reason for that, I think, was because in these health systems they only saw the specialist once, and the specialist wasn't going to be able to follow them up, and therefore didn't actually initiate any changes to therapy. So unfortunately, it does fall in many health systems if the GPs don't get more actively involved in heart failure follow-up, then the patient is not likely to get much treatment recommendation change.
Yeah, there is a question from Thomas saying that what is the potential of increasing patients' adherence to improve the outcomes?
Yeah, I mean, I think that this is part of what you were saying, Mehmet, that I think with somebody with heart failure, they've got an additional chronic medical problem. And as with all patients with chronic medical problems, when we first diagnose the condition, we want to sit down with the patient and briefly, has to be brief because we haven't got that long to spend, but you still need to briefly help the patients understand why you're using treatments. And of course, with heart failure, you're using them both to improve symptoms, but just as importantly, you're doing it to extend their lives. And they need to understand that, and need to understand that that's the reason they're taking medication. And they also need to understand that you are going to almost certainly prescribe more than one drug. You're going to prescribe 2 or 3 drugs because they each work independently of each other, and taking all of them gives the patient the best chance of better symptoms and longer life. And that obviously now includes SGLT2s, which is a significant step for primary care, because if we're already a little bit behind with existing treatments, we need to be encouraged to think that we should be adding in SGLT2s. As Sadi said, the fortunate thing about that is that they are much easier to use than GPs probably think they are. But they are a new class that we do need to be introducing.
Yeah. So
Yeah. We must talk. We need to spare some time for them. They should know what's expecting. So I mean, if they know what is beneficial for them, then I don't think that they would not accept this. But we must spare some time. And another thing is maybe the more use of single pill combinations to improve the adherence. Yes, as you know, it's very important to use single pill combinations to adhere the adherence of them. That's what I had to add, Richard.
there are interesting questions. Maybe we still have time. Sadi, one of them is one of our colleagues are thanking to your presentation also, but she says that, do you recommend using dapagliflozin and empagliflozin on the patients who have diabetes but not heart failure, but has a family history of heart failure as a prevention?
Well, Mehmet, actually, there are some studies that has been conducted in high-risk patients with diabetes, and the results were very in favor of using SGLT2 inhibitors because they improve the survival in this kind of patients. So it is not necessary that the patient should have heart failure to initiate these drugs. These drugs are very beneficial even in those with diabetes and, let's say, coronary artery disease. If we use these drugs in this kind of patients, then we may have a very good opportunity to improve the survival.
Yeah, I mean, I would agree with that. I think, remember that in diabetes, the main reason you're going to initiate an SGLT2 is to improve the blood glucose. And there are obviously different classes of drugs you can use to that. But at the moment, the use of is more commonly things like sulfonylureas, but we know they're associated with very significant risks of hypoglycemia, or DPP4s, which are commonly used. They only improve blood glucose. There's no beneficial effect on vascular events. And of course, in all patients, we'll be using metformin. And the reason for that is it's not that effective at reducing blood sugar, but it does have a modest effect on vascular events. And as we know, patients with diabetes are going to get accelerated vascular events. And yet now we've got a class of drugs that will improve blood glucose and also very significantly improve vascular outcomes. So it's certainly logical to consider in anybody who has increased vascular risk, other risk factors for vascular disease, or poor family history, etc. It would be perfectly reasonable to add in an SGLT2 ahead of using something like a DPP4, and personally, I would use them ahead of sulfonylureas as well. So, and that's permitted in the guidelines. So it's certainly a reasonable practice.
Another question in connection with this one, just to continue. How we explain patients that they are getting anti-diabetic medication when they do not have a diabetes mellitus? This is the question.
Well, I mean, these days, frankly, you're not going to introduce SGLT2 as a diabetic medication. It is a drug which has multiple effects on metabolism. It does improve their blood glucose, but it is used in this instance, it's being used because of its primary effects on heart failure. We're going to get the same issue because of this class of drugs are going to be increasingly used as well for CKD. So that's going to be yet another big clinical indication for the class. So I think we're going to find better ways of describing them. whether that is that they basically are drugs that beneficially influence a lot of aspects of metabolism, I think we'll probably be experimenting with how we talk about them. But they aren't just diabetic drugs. They're drugs that influence blood glucose alongside lots of other physical parameters.
Mhm.
Yeah, well, the endocrinologist named this drug as anti-diabetic drugs that reduce cardiovascular outcomes, but I named this drug as a heart pill that reduces blood glucose. So, it's not only an anti-diabetic. So we can, as you see in the DAPA-HF trial, the non-diabetics has a great benefit of using this drug. So please do not name it as only an anti-diabetic.
Yeah, perfect. Yeah, that's very good to know it actually from our side actually. So one question is from a cardiologist, I think. Thank you so much for the great presentation. How can we prescribe SGLT2 inhibitor as a cardiologist? It's only our decision, or we have to consult with endocrinology. What is your opinion? The cardiologist.
I don't think that we have to consult this with an endocrinologist, because as you see in the DAPA-H failure trial, being diabetic is not necessary to initiate this group of medications. So it's not necessary to consult with endocrinologists, and maybe it is one of the most user-friendly drugs that we can face it at all. Mehmet, yeah, there is no clear contraindication for this drug. It's very easy to initiate it, and we do not have such hard measures for the follow-up. So no need for an endocrinologist consultation. That's what I guess.
Perfect. So another question is, very interesting. One of the reasons the GPs, general practitioners, family doctors fear using higher dose range of medication is risk of hypotension in elderly, frail patients causing falls. Is that something justified? One colleague asked.
Is that for me?
Yeah, for, whichever, I mean, just this is something like the beta blockers, for example. Sometimes we are really, in practice, we see that, it increases the falls, for the elderly patients. So is that something also worked? I mean, is there a kind of causing falls? Is that justified? Was that worked, or is there any kind of result on any studies causing falls or something?
No, I mean it has a marginal effect on blood pressure. So like with initiating all new treatments, particularly with somebody with heart failure, you're going to follow up and recheck things like blood pressure. But it has a marginal effect on blood pressure dynamics. And remember, the important thing from the trial was that actually adverse events in the trial was equivalent to taking placebo. So it wasn't observed as a significant issue. But obviously, you would monitor blood pressure and indeed pulse in all of your patients with heart failure. But just coming back to the other message about how simple these treatments are, I mean, in DAPA-HF, it's 10 milligrams once daily of dapagliflozin, which is, basically one pill a day therapy means it's pretty easy to initiate.
Yeah. One of our colleagues, well known about the work on diabetes in general practice, he's really organizing very good conferences about it. And he's asking, would you treat a diabetic patient with SGLT2 without previous diagnosis of heart failure? Without heart failure, would you use this drug for the diabetes patient?
Of course I do. Because first, it's an anti-diabetic drug first, and secondly, it reduces cardiovascular events. So why do not? I think the answer is yes, definitely yes.
I mean, to be honest, I think if we personally develop diabetes, then what drugs are we going to take? And I can tell you, I would not want to take a sulfonylurea because, yes, it's cheap. Well, it's cheap on direct drug costs, but I wouldn't want to be risking hypoglycemia. I wouldn't bother with a DPP-4 personally because, yes, it'll drop my blood sugar, but it's not going to provide me with any added benefits. So personally, I would want an SGLT2 inhibitor. And if that wasn't sufficient, then I'd want a GLP-1. And I think, frankly, guidelines are often driven much more by what's the lowest cost of something rather than what is in the best interests of our patients. But of course, that doesn't necessarily factor in all these secondary costs, because as soon as you start getting patients needing to be admitted to hospital, the cost of the individual drugs goes completely out of the window, because all of the costs associated with admissions, if you can avoid those, then, that factors in, that should be factoring into our decision.
Can I ask you, what about the heart failure patients? Do they have any kind of, problems in their private life? Can you just summarize, which you have seen more heart failure patients than many of us, so that's the reason I'm asking. What are the tips that you could give us about specific questions or interesting questions your patients asked? And not about the treatment, but maybe just you can say to us that those are the interesting questions and those are the answers.
Sadi, you want to keep that?
If you ask me, maybe they got scared of asking or they got shy of asking. But the important question is it safe to have sex for heart failure patients? Can I talk about this?
Yes, please, just go on. This is an interesting question.
Okay. It's safe to have sex for heart failure patients. Actually, it depends on how sick they are, but in fact, the energy consumption of sexual activity is similar to mild to moderate exercise. So if a patient can walk up 2 flights of stairs, they can have sex with their partners. But if they want to have sex with someone else, then they have to be able to climb 4 flights of stairs. And you know why? Because having sex with a stranger or with someone other than a usual partner, especially if they are much younger, requires more physical effort, Mehmet, as twice much as the usual partner. And most of the cardiac deaths occur while having sex with someone else, okay? So heart failure patients should think twice before cheating on their partners.
Do you think that the SGLT2 will be very beneficial about it also?
I have no idea. Honestly, I have no idea about that. But maybe if you help the vessels and the heart, then I believe that you will help the erectile dysfunction as well. So it may improve the erectile dysfunction, but there is no study demonstrating anything about that.
Well, I mean, if I gave a comment that was slightly less useful than those comments, Sadi, but at least it applies to women as well as men, it would be, well, actually, that's a terrible thing to say because, of course, women may be as likely to have an extramarital affair as men, I suppose. So I better take that one back. But the one thing I would encourage you to talk about with your patients is that many of them are significantly reduced in lifestyle. They don't do as much visiting and shopping and family occasions because they're often limited by symptoms. But they'll often think that that's because they've got old. So they think that they're short of breath and unable to do things just because they've got old. And of course, if they've got heart failure, it is likely to be primarily down to their condition. And what they need to understand is that by taking evidence-based medications, they will actually, in most cases, get an improvement in their symptoms sufficient to improve their quality of life. So you want to encourage them not to just accept their reduced physical state, but to feel that actually by attempting more management, more active management, and that also includes increasing exercise, etc., which might be in the bed rather than on the walking around the park. But whatever the exercise is, that's worth increasing as well. But it is worth them trying to improve their quality of life. And not to just accept that a slow decline is inevitable.
Perfect, and it gets more interesting and interesting. Now I'm just turning back to the last question because I think we are almost over time, and I would really continue 1 hour more with this kind of conversation, which is lovely and very beneficial, by the way. And I think I shouldn't leave this behind. He's asking if SGLT2 inhibitors cause urinary system infection. What do you think about this? This is the question.
Well, what I know is they increase the incidence of genital infections, not the urinary tract, but maybe some increase in the urinary tract infections as well. But the main problem is the genital yeast infections, increased incidence of genital yeast infections. So the hygiene of the diaper region is very important in patients who are using SGLT2 inhibitors. That's it.
I mean, basically, these drugs are reducing glucose by increasing excretion of glucose, and you can imagine a more sugary urine, because you're excreting glucose, is going to increase the likelihood of things like yeast infections. So I think, as has been said, it is unfortunately one of the known risk factors. Very rarely you can get more serious infections down there, and therefore patients should be aware that they are at a slightly increased risk of this, and you would give the same advice as you'd give anybody who developed yeast or candidal infections down below. It's the same sort of advice about helping to avoid it.
Thank you very much, really, for both of you. I mean, this is an excellent summary from both of you, and I think we would very much like to continue, but we already completed our time, and I hope we can do one more, because you are very good. I would like you to be together, both of you, in another session, if it's possible for the future. Sadi, I am thankful to you because you have accepted in the very last moment, and although you are having very workload is really increased for you, I know. And Richard, just I know that it was not the best day for you, but I think you are already putting yourself for us for today. Thank you very much for participation and very good summary. I am more than happy to be with you, and I think we have to end it here. Thank you. And the video is in our website. I would ask you if you can watch or recommend those old colleagues who would like to see your comments here, because they are all very important comments. Thank you very much.
And given that it's a Friday evening after the end of a busy week, thank you very much for the audience, because I think we're both very pleased that we weren't talking to nobody, but actually there's been a very good audience this evening. So thank you for hanging on to listen to us this evening.
A few minutes ago, I have seen more than 180 people are right now online. So this is because of you, I think. Thank you very much.
Have a good weekend,
Thanks so
everyone.
much. Bye.
Have a good weekend. Enjoy. Bye-bye.